With us this morning, Catherine O'Neill from Green Mountain Care Board, just to talk about H266 and some of the conversation we had a little bit yesterday. And from our James who just
Thank you, everyone. For the record, I'm Catherine O'Neill, Director of Prescription Drug Pricing at the Green Mountain Care Board. This is a new position that was created last year as a result of Act 134. And the purpose of that act is to task the Green Mountain Care Board with exploring options and a methodology for implementing a program to regulate prescription drug costs. So I'll just start by saying currently the Green Mountain Care Board does not regulate prescription drug costs. So we are working with some vendors to explore options, looking at other states and the ways in which they regulate prescription drug costs. We're doing some analysis on the current state and the potential future state and looking at opportunities for savings. So with regard to the current bill, one thing that I would like to share, this is not related to the bill, but up until now, and I think even this year as well, we do collect 340B revenue data from hospitals, but it's just in the aggregate, one line. We just ask for the total revenue. We do also ask hospitals to report in their income statement line called specialty pharmacy. It's a very large dollar amount, and we realize that we define what that bucket of revenue should be pretty inexactly. And so we don't know all that's going in there. So this year, and this is separate from H266, just to be clear, this year in the budget guidance, we are asking for a little bit more information. So we're going to be asking hospitals to report total revenue from the 340B program, total revenue from patient cost sharing, the total expenses associated with the 340B program, and their estimate of profits from the 340B program. It may not be exact, of course, but we're making an effort to see if we can collect a little bit more information from the hospitals. So this bill, H266, is going to take that another step further. If it is enacted, there's some more detail in there that we would request of hospitals. So we support that. We support price transparency, and the students who sent it to you had great ideas, great strategies, and we did work with them a little bit to set them up for their research project. And so we're certainly supportive of what they're recommending in the future. So that said, you're considering now adding in 120% cap on ASP, or the average sales price. And I think from the Green Mountain Care Board's point of view, again, we don't regulate prescription drug costs. What that's going to do is limit the revenue that the hospitals would receive from Blue Cross and Blue Shield of Vermont. That's going to, I think, bring down it'll be less revenue for the hospitals. It would be less being charged to the insurance companies or to Blue Cross and Blue Shield of Vermont specifically. And we would support that. We would be okay with that. It would be a statute that would enforce that relationship on the payer and the hospitals. So I think that's the extent to which I could talk about it. It certainly would be, dollars savings, that's been already discussed, so.
So in this year's budget guidance.
Yes.
So currently we collect information from hospitals on the revenue that's generated from 340B. And then there's also revenue generated from specialty drugs. Is that what
It's specialty pharmacy.
specialty pharmacy? Yeah. But we don't collect data on, say, 340B expenditures.
Right, nothing more specific than just.
Will be this year. So we'll be able to figure out the difference between the cost of it and the revenue generated, essentially what the profit is.
What we'd like to do is see what we get from asking for this reporting. And I don't know if it would be enough to really confidently say that we could answer that question, but
And of course, 266 has a lot of hospital reporting piece in it that they.
yes.
Okay.
And it does have that phrasing about any additional information in a form and manner as prescribed by the Green Mountain Care Board. That would be great because then we could have some flexibility in what we ask for going forward.
Great. Any questions? Yeah, go ahead, Tupper.
Madam Chair, could I ask Blue Cross Blue Shield representative a question?
You may.
Thank you. If everything in 266 happens, what effect does that have on rates going forward?
You're talking about the white bagging,
Probably,
right? So the one piece that we estimate to save money is the white bagging piece. So, and we don't know exactly because we don't believe we can white bag every single drug. Roughly our equivalent to white bagging, if we could white bag every single drug, we estimate we could save $46 million across the whole book of business, not just qualified health.
how does that relate to me paying my premium?
Um,
No, I mean, not me, President, just
So it's
The
more
individual.
complicated than that, I'm sorry, because it's not evenly distributed across qualified health plan members, Vermont, state of Vermont employees members. We would have to divide it among all of those, different lines of business based on their usage of specialty drugs.
Okay, what I'm thinking about is the situation, the Blue Cross financial situation now, as we said, that we're trying to deal with. I was just wondering how much of the positive side of it could go to the rates that I would have to pay. You know, you wanted to get to 2% or something like that in reserve to keep the company solvent.
Okay. I can't give you again an exact number, but in the estimate that we provided to everyone, saying if the rates were 20% and you wanted to reduce it to 5%, you needed to find 200 million in savings. That was only for the qualified health line of business. And we assume in that number a 7% contribution to reserve for Blue Cross and Blue Shield of Vermont. So anything that you can get down, we have built in the 7% CTR, so there's no reason.
So it's not gonna get down below 7.
We feel that we need to contribute 7% to our capital,
Okay,
and then anything above that can reduce rates.
okay, thank you.
Can I ask a follow-up on that?
Sure.
Just quite simply, if we capped ASP, would that have an effect on, let's go through one by one. Would that have an effect on the amount of money that is spent on state employees' health insurance?
Yes.
So that would,
Wait, no, state employees, it would, but not through Blue Cross.
yes, but Blue Cross Blue Shield as the TPA administering that would be paying a lower rate to hospitals for those drugs. So therefore, the state of Vermont would not be paying as high a price as they are now. Which in turn would be advantageous to, say, taxpayers, right?
Yes, just to be very clear, Blue Cross does not do the drugs for state of Vermont that are retail drugs. We only do the medical side drugs. So it depends on
Yeah.
how this is actually.
But if it's a hospital
Rex would save the
outpatient,
money too.
if it's a hospital outpatient, it's a medical claim, not a pharmaceutical claim. We
Sorry
establish
to get
that.
complicated, but I don't want to.
So, Likewise, teachers,
Teachers.
the teacher's health insurance plan would have lower costs than they would have without this. Therefore, impacting property taxes. Would small businesses, employees pay less than they would have normally barring any of this?
So I'm gonna say yes, the rates we filed doesn't assume this, but I know that when we got to rate hearing, the Green Mountain Care Board would tell us to lower the rates as a result of the WU tax.
To reflect that,
Yeah, as long as it goes into effect quickly enough for us to do.
and the
that.
qualified health plans
Yes.
additionally. Okay. Leslie,
So I don't know if this is answerable, but I'm wondering if keeping a cap at 120 would affect access, and it sort of put pressure on hospitals not to do things and have less access for patients. Is there a way to know that? Maybe not, but that's what I'm wondering.
payment cut services?
Yeah.
I don't know how to answer that definitively. It seems like it's a high enough percentage that there's enough of a spread that there would be still revenue generated. But that's a question that's not certainly something that I feel comfortable exploring.
Do we think that's measurable? I think, I don't know how to do that clearly, but it's a question I think we need to think about.
I don't know, I think it goes to total cost of care.
Mhm.
Just because a hospital needs revenue to continue a service in somewhere, should they mark up their drugs to 1,000% of average sale price?
No, clearly no, but would they decide not to offer certain drugs? I mean, just. I'm
Or
thinking-
services.
Or, yeah, I'm thinking within that, or.
Or certain
Yeah,
services.
like, how do they,
It's a balance. I mean,
does it, do we want to,
it's hard decisions, I guess is what I'm trying to say.
how do we, is there a way to figure out what we've lost? Maybe not. I don't know that answer, but that's a worry.
I'm also worried about a 23% increase in.
Well, there's a lot to worry about, clearly.
Woody,
I think 120% seems rather high to me. Maybe UVM Medical Center could afford something like that, but some of our other rural hospitals might find it difficult, and as we've said, might cut some services or cut some medications. So I don't think 120% across the board is the right way to go. And then I guess I'd like to ask Blue Cross Blue Shield the question, with all this savings, what is Blue Cross Blue Shield doing? I'm sorry for the job, but what is Blue Cross Blue Shield doing to help that cost in this endeavor?
Sure, I have a long list. I can rattle off a few things right now, but I'd actually love to come in and talk to you more holistically. We submit this to the Green Mountain Care Board as part of our rate filing, a list of all the programs we have to cut costs. I can name a couple off the top of my head. For example, we've invested in Civica RX, which is a not-for-profit drug manufacturer and distributor in the United States, and they are starting to deliver drugs to our patients that we're seeing real savings. Next year, we'll get insulin at a savings. We have, I mean, a lot of the things we used to do, we're no longer allowed to do, things like step therapy for drugs. I have to be real, those are tools that insurers use to contain costs. We negotiate with our PBM to get the best discounts we can for Blue Cross and Blue Shield of Vermont members. When we affiliated with Michigan, we substantially increased the discounts for Vermonters. That was part of the scale that we were working on. So those are three things I can, say off the top of my head. We have some other contracts with different vendors that help us manage the drugs. So I'm focused a little on drugs right now, but I think one of them is called Synergy. There's a few others that we do. But I think I'd love the opportunity to come and talk about the whole list of things that we do, because it's pretty comprehensive, but it's a little bit of nibbling around the edges of healthcare costs. And when the prices are going up at double-digit amounts, the goods, for the drugs and for the cost of care, it's very hard to manage that with the tools that we have.
Okay, thank you.
Can
And
I ask Sarah a question based on your question? Because Woody makes a wonderful point. And I had asked yesterday, we have a number of what the average sales price in the state of Vermont is, but we do not have it by hospital. And to your point, I think we might find that some hospitals are actually at that amount already. So, I mean, before you make a decision on the number, would it be helpful to see where each hospital is at?
yeah, I think so.
And the only organization I can think that could get us that information would be Blue Cross Blue Shield or MVP.
And then the other issue is with white bagging, because of security and safety issues. If we continued if we didn't our bill currently asks to rescind white bagging, is that correct?
Is there
Yeah.
the ban on yeah.
Yes. So if we put it right back in, is there any cost savings there? You mentioned $46 million savings if we do white bagging. If we didn't do white bagging, is there?
I think Sarah said that if every single drug was white bagged, that was their estimated savings. Would that take time for you to put the policy in place? And
Definitely, white bagging is more complicated for the insurer and the PBM to administer and to get up and running. We haven't done it in the past. We're willing to do it and work with our PBM to do it, to get these savings, but it's capping the price and letting the hospital deliver the drug the way they currently do is far simpler. If you want us to white bag, we will do it. It's just gonna take longer and it's not gonna be as efficient and it won't get the perfect savings.
Alan?
What's the safest process for our patients? We talk about, I work for the Postal Service. I know how some things can go to the wrong address. So what's the safest to our patients?
I think
I think we've got to really look.
I think every single witness has testified that the safest is to continue the ban on white bagging.
No white bagging.
No white
Have
bagging.
the hospitals take care of it.
Enterprise.
And also I keep thinking back to Blue Cross's, if we do white bagging, the savings go to a pharmacy benefit manager. if we do ASP, the savings go to Vermonters. I mean, the hospitals get some. And the hospitals get some. I want to remind everyone, average sales price is not wholesale acquisition. It's the average price, which already builds in profit.
Whack or the mac.
Wackadoodle. Go ahead.
And hospitals still can purchase drugs in the 340B program at potentially a significant discount.
Leslie?
So we heard from the students that one of our hospitals is not doing the 340B program. I don't know which one.
Yeah, which, is it Grace Cottage?
It's great. They have a pharmacy, in-house pharmacy or next door pharmacy, but I don't know. But I was wondering about that and whether, because I imagine they're doing some of the same drugs, you know, infusions and whatever, because people need them. And is there a way to get information about their pricing to compare to 340B pricing? If that would be interesting.
It would be very interesting. Again, I think it would be really, really useful if we could get some sort of guidance on where our hospitals' prices are at right now. Mike Fisher.
My fishing, can I just, I think correct something I said yesterday? Update something I said yesterday. I heard the really specific question from Representative Vaughn about how do we land in the number? And I want to point to the Millbury College students on slide 9 have I think a well-reasoned justification or argument for the 120%. And they found the number, which I didn't have, and we should double check it, that 340B hospital purchases are around 65% of ASP. And so they present the math to show that gives hospitals a 55% markup. At 120% of ASP, it gives the hospitals a 55% markup. And so I think I said yesterday that it might be reasonable to look at a national average. I want to pull back from that. I don't think that's reasonable. I think we have to do our best to get a good sense of what 340B is in reference to ASP and recognize that the consumer, Vermonters need savings desperately, and hospitals need some revenue out of this too. 120% seems like a reasonable approach. And that doesn't mean I've stopped looking at it. We're doing some consulting with the national experts on it, and we'll update the committee. Get into that.
I don't know, one of my frustrations, well, in years on this committee, but particularly this year, is I don't mean to channel the former representative from Clarendon, but why is it that we just don't pay for the services? Why don't we pay the right amounts for the services that we provide? Why do we use one type of service? Why are we using prescription drugs to subsidize primary care? Why are we using our emergency departments to subsidize some other loss leader? Why don't we just pay for the types of services that we need and that we pay the cost of that care at a reasonable amount? You can even calculate in a little profit if you want. And that is what we've been trying to get to with reference-based pricing. We have that whole area. We are moving the Green Mountain Care Board for reference-based pricing, which the point of reference-based pricing, and the reason they have 2 years to do this, is to allow them to set the rates for all the types of care to ensure that the types of care that the rates are paying for are actually going towards those services where they're required, where they're needed. I mean, that's the whole point of reference-based pricing. That's going to take years to get to. This right here is the first step in reference-based pricing. And we, as the legislature, who have been sitting around this table for the last 4 months talking about that's good for the future, but what are we doing right now today? To me, this is one thing that we can do today that will have a direct impact on the amount that Vermonters are paying for their health care. I think Blue Cross Blue Shield put up yesterday the slide that, I don't remember how many dollars it was, $62 a month or $38 a month or per member.
32.
$32 per month per member. That's all members. That's not just the members who are utilizing those services. Every single Vermonter who has Blue Cross Blue Shield is subsidizing these huge markups. And I'm just going to make the case that, I don't know, this seems like a no-brainer to me. And will it be painful? Will it be difficult? Will there be consequences? But this was never going to be pretty.
Are you referring specifically to capping the price or to reference-based pricing?
I'm talking about the situation that we are in right now in our healthcare system within the state of Vermont. And, you know, all these entities wanting to move slowly, cautiously. We don't want to, we don't want to lose services. We don't want to change. We don't want to change. Change is really, really scary. And the alternative is the alternative is scarier. Doing nothing is scarier.
And if you don't do something, you're not gonna have anything to change.
Yeah.
Pretty soon.
All these things, 2 years, 3 years, 4 years, there will be nothing to change.
And I think we can still move cautiously.
Yeah.
We are getting really wonderful information from a lot of different corners of the system and working really collaboratively with stakeholders.
We are. I think 126 is moving cautiously. I think 482 is moving a little less cautiously, but still, it's not an immediate. But I think that it's pretty clear we need to do something immediately. So I really love the numbers of each hospital, so we know who we're affecting. Okay.
Woody's thinking about.
Woody's
something over
thinking.
there.
Well, I'm just thinking, I'll just say it, you know where we're moving. And if our friend Brian was here, we're slowly moving towards universal healthcare with all our actions. I firmly believe that.
Wish.
You can't do that unless you do it nationally.
No, well,
Actually, I kind of disagree with you, Woody, because I will think about what would happen. What would happen in the state of Vermont if Blue Cross Blue Shield failed, multiple hospitals failed all at the exact same time, provider groups disappeared, our system of FQHCs wouldn't be there. You know what the only thing that would be there to step in? Probably the state. Either that or we don't have a
why do
healthcare
those things
system.
have- Let's surmise, why do all those things have to fail by going to universal healthcare?
No, I'm not saying by going to universal healthcare. I'm saying that the trajectory we're on right now without universal healthcare, if it led to all of that, there would probably be no option other than coming in with an emergency system of universal healthcare.
Yeah.
So I think letting the system collapse moves us more towards Brian's,
I think little by little, we're moving towards universal healthcare. I really do believe that.
Is that good or bad? What's,
There's some good things and some bad things about it, just like everything. You have to weigh the good and the bad. But ever so slowly, I see us moving towards that.
how do you see,
go ahead.
how do you see this moving towards, like the capping the drug prices moving to that?
Well, here again, it's price controls. That's one aspect of it. Limiting the amount of profit that a company can make in the hospital. Those are some of the things. I see our friend from Green Mountain Care Board.
I couldn't hear.
Oh.
I
To justify.
It is really important conversation because we are trying to, because Springfield Hospital, I'm sorry, as a perfect example, we put $12 million into Springfield Hospital to do exactly the same thing that they were doing before they went bankrupt. So I was very concerned about that. So more failures is not gonna be, it'll get people's attention. And does it have to be that way to get our attention to make change?
No, I don't think so.
I use two scary words. How do you feel about monopolies price gouging?
Well, I don't care for monopolies, obviously.
Or price gouging?
Or price.
I'm gonna go Lori and then Mari.
So I think this is a really great conversation. And yes, I agree that we need to do something to bring down costs. But I think what Leslie put on the table is that there is going to be a direct effect on services. And so, I think we also have to make sure that we take that seriously because Vermonters want both, right? They want lower prices, but they want good access and good quality and services. And I think what happens, and I think it's happening now with one of the hospitals who is trying to close their birthing center. And I just heard something the other morning when I was getting ready on BPR that, the public is now in that community, like protesting the closure of the birthing center. I'm not making any statement on whether or not they should, but it's putting that hospital's administration in a really tough spot of, yes, we have to cut. And now legislators and the public are saying, no, you can't cut that, right? So I think, I think we have to keep all of it in mind as we make really, really hard decisions. And I do think access will be reduced with these changes we're making. I think that has to be said, and I still think some of the changes have to be done.
But, okay, so maybe that birthing center's cut because let's just not the stage, but births are going down. They don't have the revenue coming in, but there's also another issue. The restrictions on hospitals on what their profits can be through our Green Mountain Care Board, which also has an effect on the services that they're able to maintain. We saw that with the UVM Medical Center.
But if we don't have some type of price control, how do we control premiums?
I don't know.
Right, okay.
I don't have the answer.
I don't either. It's very hard.
I'm not sure if I read this or what. I also think that Copley has indicated that they're not closing it necessarily for somebody else. It's that they've been wanting to close it for quite some time. That it's just the community who is saying we want it. Copley isn't.
Right, but the point is, they're trying to
Yes.
close something.
Yes.
And the community and
Same.
legislators are coming out against it. While the 11 of us sit around this room and try and make really difficult decisions on where we make changes, is my point. And so we have to know that changes in pharmacy, because hospitals, good or bad, rely on it to cover other things, will have a direct impact on other things.
Murray.
Woody, to your point about universal healthcare, I think in one, to some degree, yes, I think adding increasing regulatory framework would be part of a universal healthcare system. But I think what we're missing and what I agree with Representative McFawn that I don't think we can get to as a state is the biggest, most problematic piece, which is who pays and how do we pay? And yeah, I don't think we'll get there.
Where's Brian when we need him?
Look at, Brian knows that. It's the philosophy. It's the, process. I agree that I have felt for a long time that we should have, healthcare as a public good. And, I tried like hell to get to that point. But I came to the conclusion that in order to do it in Vermont, that has 600 and something thousand people, half of them don't pay taxes. You can't afford it. We can't fund it. So we need the federal government involved if we're going to do it. Even if we use all of the money that's in the healthcare system now being spent. Because there's so many regulations on how to get that. How do you get Medicaid into a fund that is only going to be used for healthcare? How do you get Medicare in there? You got to have the federal government working with you.
Which one, which
And
witness,
then what happens to the insurance companies?
which one of our witnesses something about in the absence of competition, you need a strong regulator? And frankly, we don't have competition in the state of Vermont. And no offense to the board, we don't have a strong regulator because we haven't enforced regulation. We have regulation. Yeah, we haven't given them the authority. Leslie, and then let's finish up. Unless anyone has questions for Catherine. Poor Catherine is here at the end.
Healthcare committee.
One of the things that came out in the Act 167 report was this idea of regionalization. And I think that's really important in our tiny little state because we can't do everything everywhere. The cardiology example was really potent of you need 3 or 4 cardiologists to really run a practice. You're not going to get 3 or 4 cardiologists, tiny little hospital here or there. So in order to have access, it may not be 5 minutes away, but it may be 30 minutes away or even 45 minutes away. But I think we just have to accept that, decide sort of what's acceptable, and then move our system towards being able to provide that kind of access. So I hope that step by step we can get there. I don't know, and I'd be really interested in a conversation about what moving towards regionalization looks like, because I think it'll be kicking and screaming everywhere, particularly in the southeast part of the state, which is a part of the state that I think needs attention. But I think that's needs to happen.
Easy.
I very much agree with you, Leslie. As someone who grew up off the road system in Alaska, I really couldn't support that concept more. 30 minutes to healthcare was hard. But we need to be mindful about things like our transportation budget and really kind of think outside the box as we make hard decisions. But I think it's in some circumstances, it's life or death decisions, but we have to think about everybody, not just ourselves as we make these decisions.
You need push outs.
The cardiology example reminded me, if anyone has not listened to Vermont Public, I listened to it on the way home last Friday. They had sort of a day in the life of a primary care provider who practices in Island Pond. I don't know if anyone listened to that.
So good.
It's like 30 minutes.
Vermont edition.
It was on Vermont edition.
Last Monday.
It was absolutely wonderful portrait of the care in rural Vermont. And the cardiology thing reminded me, hearkening back to the olden days, when it used to be, remember, I keep asking, what is a hospital? What is a hospital? It used to be that there would be a practice, a cardiology practice. And they all had privileges at the various hospitals. And somewhere along the line, we've gotten where each and every hospital feels as though they need to have their own practice, which gets into the ability where you cannot have, when the hospital owns a practice, then you're getting into anti-competitive, antitrust things by working with other hospitals. And that's kind of, and a rural hospital just cannot sustain 3 or 4 cardiologists, which is what it takes to have a practice of one. And I don't know, I mean, we're talking about right sizing our system, and the Lyman report, I think that's sort of what he's referring to as a little bit going back to the way. That doesn't mean that people necessarily lose services. It just means it's delivered, the care is delivered in a different way, in a more affordable way, in a more efficient way, frankly. So I don't know. I said I was going to end, but
Oh, I'm sorry.
no, because then I went on a
Fascinating.
tangent.
Well, I think 126 is a step in that direction that you just talked about.
From the regionalization thinking, I'm imagining that it sits at AHS right now in their transformation work. Does that sound right?
Mhm.
Along with their consultants. So when, I don't know if we have any leverage to ask where they're at or their goals or,
Well, that's in 126.
okay, so thank you. Forgot.
Would the healthcare advocate like to, how long ago was it that the state of Vermont had below average premiums and below average hospital costs?
But I don't know, but I think when we passed Act 48, so 2011, my recollection is that our healthcare costs were below national average, though rising at a faster rate. So at some point between then and now, we crossed that line.
So in 15 years.
I also, since you called on me, I kept my mouth shut because I know this is a committee conversation. I just, looking at what is possibly coming at us and certainly coming at us nationally, I know this is not Willie's point, Representative Peach's point, but from my perspective of where I sit in terms of prospects for universal coverage, universal access, which is a little different than I was paid for. I fully expect we're losing ground. We're not going in the
that direction.
right direction, in the direction of access.
All right, everyone. Thank you. We're done for the day. So see you on the floor and we're all gonna be on the floor. Make sure support Wendy on the third reading. I heard that S53 was voted out of Ways and Means, 11-0 or 10-0-1, I think, something like that.